There is a big debate in the cardiovascular prevention world. Does LDL cause heart attacks?
High cholesterol, specifically LDL cholesterol, is undoubtedly a cause of heart disease, not the cause of heart disease.
Deep into that, still without question, higher LDL, regardless if it's small or big or fluffy or not fluffy, it's atherogenic.
Or is high LDL actually harmless?
There's not a strong independent association with high LDL cholesterol and risk of mortality. We need to look at other things like triglycerides.
There's almost no research that shows that your LDL level is meaningfully related to your risk of heart attack and stroke.
And what about Apo B?
There is no ambiguity that Apo B is causally related to atherosclerosis.
Your HDL cholesterol, even your HDL particle count, tells me very little. We must focus on the Apo B story.
Apolipoprotein B is causally related to atherosclerosis.
There is no good evidence that Apo B directly injures the endothelium.
I did a deep dive into the evidence. Are LDL and Apo B causing cardiovascular plaque and heart attacks? Here's what I found.
So, welcome. Very excited about the show today. You know, because we talk a lot about cardiovascular risk on our YouTube channel, we have a lot of people that want to see us for cardiovascular risk evaluation. So we see patients with every type of cardiovascular disease risk, ranging from Lp(a) to type 2 diabetes to inflammatory diseases such as rheumatoid arthritis and psoriatic arthritis. And guess what? We have a lot of people with high LDL. Quote, high bad cholesterol. Because of our expertise in the area, we have a lot of patients who come to see us about a unique risk factor called lean mass hyperresponder status, where their LDL goes into the 300, 400 range. I'm not going to go deep into that right now, but I will say there are many reasons to have high LDL. Now, recently, there's been a lot of debate about LDL in the lipidology community. For those of you who don't know, lipidologists are doctors who've spent most of their career studying cholesterol and fats in the blood, like triglycerides. After decades of saying the major cardiovascular risk is LDL, or what people have called bad cholesterol, they've changed their mind. Now they're saying it's a thing called Apo B. Here's why. Apo B is very similar in terms of bioindicators or indicators in the blood, except it focuses better on metabolic disease. And we'll describe much more detail in just a metabolic disease is otherwise known usually as prediabetes or diabetes. But the bottom line is that there are far, far better ways to test for prediabetes. Now, here's another point. I'm here in Mammoth Hot Springs in Yellowstone National Park in the US. As you can see, I'm in a hotel room and the Wi-Fi is a little bit poor. In fact, this is the place in the world, Yellowstone, where we have more geysers than anywhere else in the world. It's been a wonderful trip, but I've got a little bit of a problem with my flight schedule. It requires me to hit the road quickly. Jesus is going to be showing you in the next few minutes a lot of details that we've researched regarding LDL, Apo B, and other factors. Over the next few minutes, you'll learn what you need to know in risk of cardiovascular disease and disease from LDL and Apo B and their roles in your risk profile. Now remember, understanding your risk is the first step in taking control of your health. Jesus?
Hi, everyone. So everybody loves Dr. Brewer, but really, Dr. Brewer, your audio and video just doesn't help. But thank you so much for taking the time. You might not know this in the audience. Dr. Brewer is on vacation, so he's very happy away from us. And he gave me the task to go over all of this topic and, of course, mentored me as he does. So if you stay to see the full show, I'm pretty sure I have a lot of evidence, a lot of research, and some of that stuff you might agree with, so you may not. But if you stay enough, you're gonna find out the rationale behind all of those claims that we're gonna make on the show. It's gonna be a good one. And before we start, real quick, and before Dr. Brewer leaves, let me show this. So I'm jealous of Dr. Brewer looking at bisons, cup bears, and wonderful scenarios out there. So before you go, Dr. Brewer, and before I start throwing wood to the fire of LDL and ApoB, any comments before?
No, again, as I said, I wish I were going to be there for the whole show, but I've got a plane to catch.
Yep. And we can always do a part 2 of this conversation if there's something else. But thank you so much, Dr. Brewer.
There's going to be, whether we wanted it or not, there's going to be a part 2, 3, 4, 17, 18, 19. This debate is going to go on for a while.
All right.
We'll see.
Let's do that then. Thank you so much, Dr. Brewer. All right, so let's get started. That was really good for an intro. We appreciate Dr. Brewer, of course. And for those who are not aware of who I am, I'm a physician in Mexico. I work with Dr. Brewer. I'm a recently certified metabolic health practitioner. And I have spent the last week reviewing the most significant evidence regarding LDL and ApoB, sharing that with Dr. Brewer. Even he took some time from his vacations to discuss this with me. And if you're just looking for the answer about, so what's your opinion on LDL and ApoB? What's Dr. Brewer's opinion on LDL and ApoB? Let me start with the conclusions first, and then we're going to go over the data. And hopefully we can do this in less than an hour. So it's as simple as possible because, you know, this is a complicated topic. So I just wanted to start by answering these questions. And I know if you believe in your heart that LDL doesn't cause heart attacks, I hear you. There's evidence to support that claim. But I want to show you the other side of the aisle and why this is not black and white. There's a lot of gray between all of these concepts. So does LDL cause heart disease? The answer to us, the answer is yes, just because there's people with something called familial hypercholesterolemia. And there's no doubt that very high levels of LDL do cause inflammation and can cause plaque. Let's leave it at that for now. We're going to discuss, well, but what about this population? Yes, there are a lot of caveats. Is ApoB causal and better marker for heart disease? It seems that it is. 80 to 90% of ApoB is basically LDL. So it's a better marker because it includes some of the non-HDL, also ApoB lipoprotein particles. And the evidence do show that ApoB can cause heart disease. Just until there. Then next question, are they sufficient? And this is where it gets more complicated. Saying that something causes something, in this case LDL or ApoB causes plaque and heart disease, doesn't mean that it's enough, because we do also have that population that can have high ApoB levels or high LDL levels and not necessarily develop that much plaque. And we're going to discuss the latest published evidence from Nick Norwitz and Dave Feldman and others about lean mass hyperresponders. So causation doesn't mean that it's sufficient. And that's why there's a lot of conflict and difference in opinion, because every person's situation is going to be different, despite if you have the same LDL levels or ApoB levels. Is there another major cause? Of course. And to us, that other major cause of heart disease and plaque buildup is insulin resistance. So there are other causes. It's not just LDL and ApoB. Do doctors neglect other causes for LDL and ApoB? All the time. Every day, your usual medical visit is going to be, oh, your LDL is high, or now your ApoB is high. Let's put you on statins, ezetimibe, bempedoic acid, PCSK9 inhibitors, and put that down. And neglect all the other stuff that is around. Some even ignore high HDL, some ignore high triglycerides, or just put it on the same category, and don't see that can be a reflection of a poor insulin resistance. Almost nobody is measuring insulin levels other than the people who are on functional medicine or on a preventive space like we are. So if we're lucky, they're going to measure home IR, or maybe do something else than A1C. So definitely there's something else. Are LDL and ApoB a risk factor for everybody? Not necessarily. That's kind of the difference. And at the end, I'm going to show you the latest publication from Dave Feldman and Nick Norwitz regarding lean mass hyperresponders. They have already published the most recent data they have so far. Yes, there's still stuff that needs to be done. There's a lot of research that also needs to be done, but we now have some evidence that we can rely on to start figuring out this conundrum. All right. So I just want to do a quick recap of lipid metabolism. I'm going to try to make simple a very complicated topic. There are a lot of processes, but in a few words, basically, lipoproteins are kind of the ships of the transportation system for cholesterol, which, cannot mix with water. That's why serum plasma needs all these particles to move around that cholesterol and triglycerides, both that can be produced either by the body or that you are consuming in your diet, fats or triglycerides. Or even if you're eating carbs, those carbs are being transformed into triglycerides, and then they can get transported. The liver is going to put out some of those lipoproteins once it receives that cargo from the lymphatic system, when this is coming from the diet or the triglycerides the liver itself is building. And those lipoproteins start as a big fluffy lipoprotein called chylomicron, which I'm going to show you, have a lot of triglycerides, to start dropping the triglycerides, and it gets smaller with mostly cholesterol and less triglyceride content. They become very low density lipoproteins, intermediate density lipoproteins, and then low density lipoproteins. The lower the density, the smaller the lipoprotein. And then you have a lot of those LDL particles that can be reabsorbed by the liver with the use of the LDL receptors, or they can travel around the body still, right? One of the organs that receives most of those triglycerides and some of that cholesterol are the muscles. So that's one of the organs that receives all of that. Other organs can, but every cell can create cholesterol on its own. So it's basically more of the triglyceride transportation. And in this image right here, you can see kind of a visual of that representation. So on your right, you will see the chylomicron with a lot of triglycerides on blue, some cholesterol in yellow. Then it starts dropping triglycerides. It becomes an VLDL, very low density, then IDL, then LDL, right? And all of those share a common thing on their own, a marker that is called ApoB, which is kind of an adequate for that. And that LDL has different portions, different structures. It has a phospholipid layer, which is made of phosphorus and lipids, an ApoB marker on top. There are different types of ApoB. We're going to focus on ApoB 100. Cholesterol in the inside, some cholesterol in the outside, and triglycerides in the inside as part of that cargo that LDL transfers or transports. So LDL does have a function. And actually, one thing you might heard before is that the relationship between HDL and LDL is very, very tight. Even though it is thought that HDL can transport lipids and cholesterol and some triglycerides back to the liver, it does. It also does that through LDL. So they connect, and LDL can transport some of those triglycerides and cholesterol that it's capturing from HDL actually, and sending that back to the liver. So complicated process. All those lipoproteins have a role. The problem is, like a lot of things in toxicology and human body, is the quantity that matters. Another thing that you might want to know regards to physiology of those lipoproteins is that LDL is that lipoprotein that lasts the longer on the serum. VLDL chylomicrons don't last that long because they just drop the triglycerides to the muscle. It gets burned for energy, and then they basically disappear. So from your lipid panel, it's less than 20%, 10% of the substances that you will find out are chylomicrons or VLDL, IDL. Most of that will be LDL. And then this is the whole theory behind of why LDL and ApoB cause heart disease. And if you listen to mainstream doctors on YouTube and some of the research that I'm going to present, the theoretical aspect is that it's not so much, according to this, it's not so much the amount of cholesterol that those lipoproteins have, rather the particles. And they make the analogy of a traffic jam. So if you have a lot of LDLs, a lot of cars, it doesn't matter how many passengers, a lot of cars, a lot of ApoB, which will include LDL and all the other remnant lipoproteins we mentioned, IDL, VLDL. When that thing you see here, any particle that is less than 70 nanometers can go through the layer of the intima on the artery. This is the intima. This pink line of cells is basically a representation of the intima. So basically, any lipoprotein can go through it. ApoB gets captured by macrophages, which are immune cells. It gets oxidized, and then it starts creating something that is called a foam cell. A lot of cholesterol on it creates more inflammation, and then it dies. And this is what we call the necrotic core, which is basically the source of plaque, right? They say it's just enough with the amount of ApoB particles and LDL particles that you have to cause all of this. Our perspective is a little bit different. We do believe that a damaged endothelium because of cardiovascular inflammation can trigger this more rapidly. And even though it's possible that ApoB lipoproteins do that, they cross and they create inflammation from the inside. That's something that can happen. If you only rely on thinking that that's the only and solely mechanism for plaque creation, you're going to neglect a lot of other inflammation causing entities like insulin resistance. So as you see, it's more complicated than that. ApoB has the potential, or ApoB lipoproteins have the potential to cause inflammation from the inside. That's something that can happen. But most people do have other stuff like metabolic disease. And we're going to present a popular paper that shows up what's the role in regards to risk of LDL and ApoB compared to other cardiovascular risk factors. So that's kind of trying to simplify the conundrum. There are more mechanisms, but this is kind of the main one, which if you think that is the quantity of ApoB lipoproteins causing plaque, then you can understand why most doctors are pushing statins, and not just pushing statins, pushing high dose statins to try to lower this down. Now, first study the mainstream doctors are using to say, look, this is the evidence that LDL causes heart attacks and strokes and heart disease and more mortality. So this is an article that's coming from the European Society of Cardiology, published in 2017, about low density lipoproteins causing atherosclerotic heart disease, plaque. And to their point, this is a strong research. It's a meta-analysis of the 100 prospective cohort studies, some Mendelian randomization studies, and some randomized control trials. 2 million participants, 20 million person years. So it's kind of the accumulation of the years that all these people were followed. The results: 150,000 cardiovascular events. Unequivocally, LDL causes cardiovascular disease. And in all those papers, I'm going to show the funding at the very bottom if you want to take a look at that. And in the description, you're going to find the links to each study. I would have loved for us to stay and review all those articles in detail. I'm just going to show you the conclusions, and you can go to the paper if you want to see more about that. But as you will see on most of these studies, most of them have some kind of conflict of interest. A lot of doctors take money from big pharma. So that's just the way it is. You can take this article as it is, and if you think that the conflict of interest nullifies the results, that's a perspective that you can have. I do think the research is strong, and I don't think we can disagree that LDL has a big role on causing plaque. The problem is, what do we do with that information on a practical basis? The next article from 2012, effect of long-term exposure to low-density lipoprotein cholesterol in early life. So Another Mendelian randomization study, which the thing about Mendelian randomization studies is the strength on them relies on the ability of minimize the impact of external factors and look at the epigenetics on every individual gene changes. And so it's a little bit more strong in the side of making a causal relationship rather than just an association or correlation. So this one, they say, well, if high LDL is causing plaque, what about if you decrease LDL from the early before going into mid adulthood, or not just focus on elderly people, like decrease LDL as soon as possible, right? So it's a meta-analysis of Mendelian randomization studies, 9 polymorphisms, which are changes on the DNA that can make changes on the way we process LDL. And it says here that they show that lower LDL cholesterol was associated with a 54% risk reduction and 3 times less risk per unit of LDL lowered in early life. So basically, they're saying the more you lower LDL, the sooner, the less risk you're going to have. The problem is, how do you lower that LDL? And what is the side effect of lowering the LDL that soon? And with how are you lowering that LDL? So is LDL the sole responsible of decreasing the risk? Or by decreasing LDL, you actually took care of other risk factors like blood pressure or weight? That's the question, right? And the idea behind a Mendelian randomization is that they are taking out the impact of all these other factors, and they are putting the benefit on LDL alone. So that's kind of the evidence behind LDL. There are more evidence. This one is from 2017. Normal LDL cholesterol are associated with subclinical atherosclerosis, meaning building plaque without feeling anything. So what they found on this one is that out of more than 1,000 participants, an extra 7 in there, 49% had plaque or coronary calcification, even with, let's say, quote, normal LDL. The range was 100 and less than 160. So if on this population that had LDL between 100 and less than 160, still half of them developed plaque. And they found out that just having an LDL between those numbers increased the risk by 1.14, which is about 14% increased risk. So as you see here, looking at just the number can get tricky. It's hard. All right, but this is one study. And then we have another one. This one is about associating low-density lipoprotein versus cause-specific mortality in Denmark. This is called the Copenhagen study. And the Copenhagen study is very interesting as well. They included over 100,000 participants, 9 years of follow-up. And these are the results. Having an LDL less than 70 actually increased the cardiovascular risk by 25%. But also having an LDL about 189 increased cardiovascular risk by 15%. They found the sweet spot on an LDL of 132, so around 130 to 140. So now you have 2 separate studies that are saying kind of opposite things. This one is saying that 130 to 140 is not increasing risk. The other one says that if you have between 100 to less than 160, you do have some increased risk, 14%. So as you see, what research did you look at? What research do you pay attention to? And the only thing you can do is take a look at all of that and try to come up with a conclusion yourself that might fit your needs, right? This one is another interesting one. This is an analysis from the NHANES surveys, 19,000 people, 15 years of follow-up, and these are the results. So an LDL less than 100 increased the risk by 30%, basically. And then the LDL above 160 increased the risk by 8%. Cardiovascular mortality. So this one that I just mentioned are all cause of death. If you want to take a look just at cardiovascular mortality, the risk of dying because of heart attack, in this study, they found out that having an LDL of less than 70 increased the risk by 60%, basically. 70 to 99, increased risk of 20%. LDL between 130 to 159, it's like about 20%. But this is minus risk, so less risk if your LDL is between 130 to 159. And an LDL of above 160 increase the risk by 50%. So, again, interesting remarks. I can tell you my own perspective and Dr. Brewer's perspective is you have to individualize. We don't think that just pushing LDL down is enough and is necessarily a good thing. Having a very high LDL is not necessarily a good thing either, and so it's important. Of course, I would love to go over more of this stuff on detail. I'm just going to show you some of the results, and the links are in the description if you want to find out a little bit more about each individual study, because all of those have limitations and all of those have strengths. So there's no perfect study, as you know. This one is interesting because this is the one that Dr. Obedia refers a lot. He's a cardiovascular, cardiothoracic surgeon, and he says most patients that come to the ER with a heart attack have a low LDL. This study is interesting because of that perspective. So they evaluated over 100,000 hospitalizations over a 6-year period of time. And for people who came up to the emergency room because of heart disease and emergencies related to heart disease, the mean lipid levels was about 104. The HDL was usually low, less than 40, and triglycerides were usually high, 161. And from those people, only 21% were on statins or other lipid lowering therapies. And almost half of them had LDL levels below 100. But take a look at this one. Only 10% of those people with cardiac events had an HDL more than 60. So that's why also I kind of reflect on, kind of think about what's the role of HDL and something to consider, because you see some lipidology saying that HDL doesn't matter, it's all about ApoB. But then you see all these studies and it's like, well, it seems like HDL does play a role. Now, some people say, well, when you're having an acute cardiac event, your lipoproteins actually can go lower acutely. So that's a limitation from this study because we don't know the previous numbers from these people. This is just when they come to the ER. Now, let's talk a little bit more about ApoB. So ApoB, we say it from now on, just saying that ApoB is a better marker than LDL. It's true because it is including some of the intermediate density lipoproteins and the VLDLs that we mentioned earlier. This one is evaluating the effects of ApoB on lifespan and risk of major diseases, including type 2 diabetes, another Mendelian randomization study. This one, the results are interesting. They included about 500,000 participants from the UK Biobank data for a 4-year period of time, and they found out that those who have a family history of ApoB elevated levels had a shortened lifespan, and those who have elevated ApoB levels also had more risk of heart disease in relatives. And this is just because they're looking at the genetics on all the family or the most of the first degree members and family members. It's basically saying if you have a genetic issue with ApoB, your risk is going to be higher, you're going to live less. Not saying yet that lower ApoB means living longer. That's kind of assumption from these results. But they're just saying higher ApoB, you might live less. And there's another one. This is an interesting one because this is kind of the article done by lipidologist Dr. Snyderman, who said, you know what, stop looking just non-HDL, non-high density lipoproteins. Just take a look at ApoB. Say ApoB is the one. And they published this with the title that the debate is over, right? And they are saying that based in the results of a large prospective study, observational study on the UK Biobank, and 2 clinical trials, the Ferreira and Improve trials, ApoB is the primary marker to assess cardiovascular risk. Okay, and this is kind of the landmark study for ApoB now, and there are more studies about ApoB, but this one is kind of the landmark because it's saying, hey, this is all the evidence that there is. ApoB is the one. You have to take care of ApoB, and the problem we have with that is that even though there is good research to be behind this, just saying that it's just ApoB, that's a problem. There are more things to consider. So Dr. Bittner actually made an editorial based on the following study saying, is the debate really over? It's just because of the number of ApoB particles that you're going to develop plaque. And this is another Mendelian randomization, so a very strong study, meta-analysis again, a study of studies. And they're saying, you know what? I have other data, and this data is actually saying that it's not the particles, it's the amount of cholesterol within those particles that is causing plaque. So we kind of come back to square one and say, okay, is ApoB is about the amount of ApoB or about the cholesterol in the ApoB particles? The evidence is still developing. And we have some of the strongest research papers that support both sides of the conversation. But both are saying ApoB, right? All right. And this is kind of the visual for that. So they're saying if you have large ApoB lipoproteins, that will be mostly LDL, 80 to 90% of these ApoB particles or lipoproteins are basically LDL. You're going to have greater risk if those are filled with cholesterol. And then the other side is, well, if you have a lot of ApoB particles that are not so big, maybe it's not such a big issue. So what's the truth? We don't know for sure. I think both evidence is compelling, and we don't have the final result just yet. That's why the debate might be still open. What I think we can all agree is that if you have a high ApoB number, there's something else that you could be doing and you can do to improve that. All right. So there's another study regarding, is ApoB necessarily a bad thing? This is just one study. So I don't think I saw another study that has the same results as this one. So take this with a pinch of salt. 36,000 Chinese subjects in this cohort study. And they found out after 11 years follow-up that patients with a low baseline ApoB had the worst prognosis, actually. But when they adjusted for malnutrition and high bilirubin, low ApoB was actually protected by 14% for all-cause mortality. So this is the whole point. It's not just ApoB. You have to take in consideration other stuff like micronutrient deficiency, insulin resistance. There are other risk factors to put in context. And this is the study that I wanted to get to make that point. This one is the women's study. It's called also the women's study. Association of lipid, inflammatory, and metabolic biomarkers with age at onset for incident coronary heart disease. So what are the risk factors before you develop cardiovascular disease? Also, take this with a pinch of salt because the authors themselves said, we don't know if we can extrapolate this to everybody because this is a study on women alone. But this is the result. 28,000 women, 21 years of follow-up, so a very large study. See what is the number one risk factor they found for heart disease? Diabetes. 10 times more risk if you have diagnosed diabetes. And remember, we're always saying this. 52% of Americans have prediabetes. They just don't know it. And by the time you get diagnosed with diabetes, according to standards, 126 fasting blood glucose, or if you're using A1C, it's been years, 5 to 7 years that you are developing the problem, that you're dealing with insulin resistance until you finally get the diagnosis. Metabolic syndrome became which used to be called metabolic syndrome. Now we call that metabolic disease, basically. 6 times more the risk. Hypertension, 4 times more risk. Obesity and smoking are high in there. Lipoprotein insulin resistance. Lipoprotein insulin resistance is what you get from LabCorp lab and sometimes Quest labs, where they take a look at the lipoprotein particles and basically low HDL, high triglycerides, or as a reflection of insulin resistance, 6 times more the risk. Take a look at LDL. They do confer risk, 30% for LDL, 80% for ApoB. So there is risk, but it pales in comparison to the risk coming from diabetes. Triglycerides, 2 times more the risk, and inflammation markers, 1.2 to 1.8, similar to LDL and ApoB. So there's more than just LDL and ApoB. We're not saying to ignore them. We're not saying it doesn't matter. We're saying if you are focusing only on ApoB and LDL, you're missing the forest for the trees. Now, look at the recent research from Dave Feldman, Nick Norwis, Matthew Budoff, the lean mass hyperresponders. And just to give you a refresher on this, lean mass hyperresponder is something that Dave Feldman brought up to the scientific community. And he's an engineer, so it says a lot that when an engineer had to come up and say to the doctors, hey, guys, there's something that you're missing. By the way, we have a lot of patients that are engineers, and we love them because they are really good at tracking data and finding patterns on their own health. So they find out that those people who are on a ketogenic or a low-carb diet, and because of that, are having an increase on HDL more than 80, having low triglycerides less than 70, but having an increase more than 200, they do have a specific phenotype, which is called the lean mass hyperresponder. And just so you remember, BMI is not a criteria. You don't have to be lean. It just so happens that these people, when they are on a low carb diet, they lose weight, and they're actually lean because of that, and they develop all this. But the lean mass hyperresponder criteria, although these 3 numbers, set by Nick Norwitz himself. So the question was, is this high LDL a problem for these people? And just right now, I want to tell you, this research is not supposed to say, oh, since in this population, high LDL is not a problem, LDL is not a problem for anybody. I don't think, not even them that they're doing the research are saying that. They're saying if you fit this criteria, maybe LDL is not such a big problem for you. And that's just because the physiological explanation behind this is they are having a lot of LDL particles transporting triglycerides, but they have on their metabolism the ability to metabolize those triglycerides fairly quickly. So they are emptying the LDL cargo of triglycerides very fast. Well, the chylomicrons, and then the chylomicrons become LDL. So they have a lot of LDL particles that they were putting a lot of triglycerides, but they're using the triglycerides very quickly. That's why they have a lot of LDL. And if you thought that, well, this lean mass hyperresponder phenotype is just weird. I mean, maybe it's a unicorn, and nobody is dealing with that. They posted this analysis, this article about how common is this. And this is a meta-analysis of 41 trials involving 1,300 participants who underwent low-carb diet to see how many of those people who start a low-carb diet can develop this pattern. And they saw that, yes, mean BMI was inversely correlated to LDL. So the lower the BMI, the higher the LDL. In this specific study, for this population, the cause was not saturated fat. It was the metabolism that they were going through. And even the BMI of more than 35 saw a decrease on LDL by 70 milligrams per deciliter. So this is a very specific population that wasn't identified before. A lot of people are experiencing that because low-carb diets are becoming more and more popular. We're drifting away from the old dogma or just avoid fats and eat as many whole grains as you want. And people are now starting to identify that it's actually the carbohydrates, and especially the processed carbohydrates, that are the problem, not necessarily just the fat. And so this is the latest study where they're publishing the most recent evidence. Carbohydrate restriction induced elevation in LDL cholesterol and atherosclerosis, the keto trial. And you see some of important names right there, like Matthew Budoff and Dave Feldman over there. And see here, this is I wanted to put the graphs that they used. So they have the lean mass hyperresponders, 100 of them. The mean LDL for this population was 272. The maximum they had was about almost 600 LDL. The HDL average was 90, and the triglycerides average was 64. And these people actually was on a keto diet for over 4 years before the start of the study. And they matched this to another study, people from the Miami Heart cohort. So they tried to make it, to pair that 80 to 80, and see from those two populations who developed more plaque. So at baseline, the lean mass hyperresponder subjects, we mentioned the mean of 272, HDL of 90, triglycerides of 64. And when they were matched, the Miami cohort had an average of 123. And the result is that lean mass hyperresponder group exhibited no increase of plaque burden at baseline, despite 4 years of extreme high LDL levels. So in this population, let me be very clear, on this lean mass hyperresponder, the presence of high levels of LDL for 4 years in average did not reflect more plaque than the cohort from the Miami Heart, which are not lean mass hyperresponders. And in this graph, you can kind of see that. So the blue lines are actually the LDL levels. The green lines are the LDL levels from the Miami Heart. The blue lines are on the keto study. And the yellow is the amount of plaque. So you see here you have some people with very high LDL on the peak, on the first peak from left to right on the blue line. Very high LDL, no plaque at the bottom. And then you have here some people with LDL around 300 that are all developing plaque. But on the Miami Heart, if you see the yellow graph, both look the same. So they are developing basically the same amount of plaque despite the LDL levels. We don't go as far to say what caused this. We're just seeing, hey, they're not developing more plaque, and this is not LDL in this lean mass hyperresponder population. We cannot say that this applies to everybody. So that's the problem. And of course, the study is still ongoing. They're just actually now publishing these first results on a paper. And this is the main problem that I see with all of this. After seeing all this evidence and seeing all of those papers that you can take a closer look at, if you go to the description and just click on them and make your own, put your own perspective on it and make your own decisions and choices. What does the American Medical Association say, which is arguably the most important entity in regards to doctors' education? So they published an article last year about what doctors wish patients knew about heart disease prevention. And this talks about the perspective on what is good cardiovascular prevention for them. And we can agree on some stuff like not smoking, keeping a good control of blood pressure, improving your sleep, having a positive mindset. Well, yeah, that can help. But look at the top. Focus both on medical and lifestyle. They are putting the same weight on drugs, pharmacological treatment than they're doing on lifestyle. Get up and move around more. It's kind of it's oversimplifying something like exercise, which needs a conversation about what type of exercise, because this can put people into the idea if aerobic exercise is enough, and it is not. There are more things to do, like high intensity interval training and resistance training that are important as well. Add more fruits and vegetables. So some fruits will actually add wood to the fire of insulin resistance. And you need to find out which are the fruits that do that for you. I can tell you for a fact, to me, I cannot tolerate bananas. Bananas just skyrocket my blood glucose. Try a single pill combination for blood pressure. So not saying lifestyle for blood pressure, go ahead and take a pill. Take steps down to lower cholesterol, not specifying which cholesterol. And there are still doctors out there, I can tell you for a fact that a lot of doctors in Mexico that think this, that is total cholesterol the main issue. And we didn't even mention total cholesterol, because total cholesterol is basically meaningless to cardiovascular prevention right now. And visit your doctor, which, well, you cannot get medical advice from a YouTube channel. So you do need a good doctor that can, with whom you can talk and discuss options for your own specific treatment, because everybody is different. So the bottom line of all of this that I wanted to show you after visiting all this information, and again, the links are in the description, is for you to think about what is your own situation. If you're on a low-carb diet and you fit the criteria for lean mass hyperresponder, then yes, that recent evidence that LDL might not be such a big problem can apply to you. But if you saw that even lean mass hyperresponders have plaque, there is a reason. You need to find out why are you building plaque. Might not be LDL, but might be something else. Might not be ApoB, might be something else. If your only problem is ApoB, you might want to take, and you are not a lean mass hyperresponder, you might want to take a look at the strategies to lower that down. And as Dr. Brewer says, putting suspenders on a belt, making sure that your risk is as low as possible. There's people like Dr. Paul Saladino, whom I agree with in a lot of things. And he says, if you are metabolically healthy, meaning no insulin resistance, no blood pressure issues, no medications, and your LDL and ApoB is high, your risk is going to be lower, and you don't have to worry about LDL and ApoB. And maybe, I think if you're metabolically healthy and your only issue is ApoB and LDL, your risk might be lower compared to most people. But most people have more than just ApoB. Most people have other problems. It's not just ApoB. So that's our position. It's not as simple as just putting down LDL and ApoB in one number. It's making sure that you're metabolically healthy, and that is taking a look at insulin, taking a look at other lipid panel issues like triglycerides, HDL, homocysteine. If you're not having autoimmune diseases, which also increase the risk significantly. All right, I'm surprised we were able to go through all that evidence in just 40 minutes. And I'm going to do a shameless plug right here. If you want to have an evaluation that is not just about LDL and ApoB and that considers metabolic health, to see if you have a problem with plaque buildup and risk of cardiac disease, give us a call. Gilbert is going to put the number right there, or visit prevmedhealth.com. All right, just a shameless plug. Right, let's go and take a look at some of the questions. I'm not gonna do the wearable. Dr. Brewer isn't here today, so sorry, Dr. Brewer. I want to go through the questions before the hour. I'm gonna do my best. If there's something that I don't know, I'm gonna make sure to ask Dr. Brewer, and maybe we can share that with you in another video. Joe SXM, I have been spared the trip to the cath lab, but I had to agree to bump rosuvastatin from 5 to 10, and I added 200 milligrams of CoQ10. Yeah, and Dr. Brewer gets a lot of, I don't want to say hate, but let's say mean looks whenever he says statins. There's a problem with statins, and it's significant. Side effects, some studies link that to dementia. It can decrease the ability from cells to produce their own cholesterol because it blocks the enzyme that does that. But it's also the reality that there are something called pleiotropic effects of statins, mostly reducing inflammation, that can help with that. And Dr. Brewer, I have never seen Dr. Brewer prescribing statins to lower LDL or ApoB. There are other medications that you can use for that if you're really concerned about it. And we rather use some of those rather than increasing statin dose. And of course, lifestyle is by far more important. Lifestyle interventions that are really good for ApoB: losing weight, high intensity interval training. So not just aerobics and resistance training, both are important, but also high intensity. And polyunsaturated fats like those coming from avocado, even flaxseed, walnuts, and omega-3 fatty acids, of course. So those are options that can help lower that part of that risk if you're concerned about it. Lucian P, is high insulin levels damaging the coronary arteries? Could high insulin explain things better than LDL? That's our whole conversation. So we had that question before. What is worse, a high glucose or a high insulin? And the answer is both. High glucose is far worse. They are more inflammatory to the artery wall. But LDL, high insulin can also do that. And you don't need a damaged endothelium, an intima layer of the artery, to start building plaque. It doesn't have to be damaged. But when you damage that with high levels of insulin, high levels of glucose, you're going to ease that process. And a vessel that is already inflamed, LDL and ApoB particles are going to perpetuate inflammation and create plaque faster. So that's when we say that both things are important. Both things matter. Lucian P, perhaps it's not even diabetes, but insulin itself, which damages arteries. Yes, that's the whole point. I just saw a patient yesterday. I believe she was like 53 here in Mexico, 53 years old. Fasting glucose was 92. Triglycerides were 200. HDL was 36. And she was told by her doctor, oh, yeah, don't worry too much about it. Just decrease the amount of fat you're eating and, yeah, avoid bread and pasta and all that stuff. Okay. And she was, but I don't understand why I'm going to do that. My blood glucose is really good. I asked her to get a fasting insulin, and the fasting insulin was 15. So there is insulin resistance. That she's requiring a lot of insulin to keep that blood glucose below 100. And that's also damaging. How do you measure metabolic health? Home IR? Yes, you can do home IR. The problem with home IR that we have seen is that there are people who will have low levels of blood glucose and not necessarily very high levels of fasting insulin. So their body is actually able to compensate, especially the youngest people. And home IR might be normal. But when you challenge those people with an oral glucose tolerance test, getting some glucose and measuring glucose and insulin, fasting 1 hour, 2 hours, and even 30 minutes after drinking that thing. It's not a fun test, but it will give you not a picture, but a video of how your body behaves. And then that's when we see either very high levels of blood glucose, or we see blood glucose levels that are not elevating that much, but then you see insulin levels that peak. And we have seen insulin levels closer to 200 or 250. That's how we identify that there's a metabolic issue. The other thing we take a look at is HDL and triglycerides. Usually, low HDL is a reflection of poor insulin metabolism. We do take a look at, even though there are people saying that particle sizes doesn't matter, we have seen that low HDL, the large HDL particles, when those are low, that's a reflection of insulin resistance as well. We do sometimes look at the LPIR score from LabCorp. The problem with that is the same thing that we see the home IR. It's better than home IR, but it can miss some cases. And OGTT and insulin responses, the test that miss the less cases, less than 5%. Joe SXM, probably not. This is an answer to JMK. Not an intention to hammer down LDL, but the first one wanted angiography, so this one seems to fair trade. Okay, so basically kind of talking about the experience on that. And that's the problem. If there's a lot of people who think, well, I'm taking statins, now my LDL is below 70 as they wanted, I'm free of risk. My ApoB is less than 80, less than 50 even, I'm free of risk. And then they can develop a heart attack if you ignore the other risk factors. What we're trying to say as a final message is don't ignore other risk factors. And the mainstream community does that a lot. They're saying, oh, diabetes is a major risk factor. Yes, but if you're waiting to identify diabetes, you are missing a lot of years of damage because pre-diabetes or insulin resistance. Why do people have low HDL and high LDL? Why does HDL get low? Genes? There's a little bit of that. HDL genetic issues, poor glucose metabolism issues as well are a reflection of that. There's people who have a genetic issue with high triglycerides, and that's a problem as well. But it's mostly insulin resistance. Road O bar, being low carb 1 year, have moderated calcium score, elevated LDL and Apo B. My CMT shows no soft plaque, some heterogeneous plaque, which is a mixture between soft and calcified plaque. Elevated GGT and homocysteine on 5 milligrams of cystatin. What else to do to get rid of inflammation? So, we of course we cannot provide advice on YouTube. If the question is what strategies are good to decrease inflammation, first thing is to find out your own risk. And as you see here, will be interesting to see other things like fasting insulin, even an oral glucose tolerance test with insulin response to have a clear picture of lipid profile, fractionation, not just LDL and ApoB. I mean, we're saying LDL and ApoB can increase risk. We'll have to see the context. If the person fits the criteria of lean mass hyperresponder or not. But the activities to get rid of inflammation is find the best diet for you. Polyunsaturated fats, especially omega-3 fatty acids, I think those are a good option. We're not so concerned about saturated fats. The standard guideline says to eat less than 10%. We don't think that they damage as many people as it is thought. We can talk about saturated fats in another show. But exercise is critical. Low carb is important. Exercise is important as well. Doing all three, some aerobic exercise, resistance training, and high intensity interval training, or at least reduce exertion, high intensity interval training, which I think we're going to plan a show on that to talk a little bit more about that. No to smoking. There are some supplements that might help, like methylated B complex, or depending on HDL on LP or LP little a status, niacin can help. There are medications, of course. So there's a lot of stuff that can be done. PCSK9 inhibitors for all? No, no. And somebody said, let's put statins on the water. No. PCSK9 inhibitors, the only scenarios where I have seen Dr. Brewer using those is people with familial hypercholesterolemia, very high levels of LDL that we know that are risk factors for them, or people for which other strategies haven't worked, like statins or ezetimibe or bempedoic acid, and they want to put down their LDL. And the PCSK9 inhibitors, what they do is the PCSK9 is basically a particle that will get rid of the LDL receptor. So by taking out that thing, the PCSK9, you let the liver with more LDL receptors that can now go ahead and process the LDL, and that way you get a decreased LDL and a decreased ApoB lipoprotein. So not for all. Medications are a thing that needs to be individualized. What will be the liver choices to do that? I'm missing the question on this thing. I want to finish before the hour, if you allow me. Were all these 1.6 being 60% mean relative risk? Yes, most of that is relative risk. And we can go to the conversation about relative versus absolute risk. And people say, well, relative risk doesn't matter. It's a statistics, and the statistics are going to be always complicated. That's why I was just mentioning, take that with a pinch of salt, because it's difficult to generalize one result of a paper to everybody. That's why you need to take a look at everything and see what applies to you or not. And it's hard to do that on your own. Have you subscribed to Dr. Berg and Dr. Ekberg? Well, I'm not going to comment on that. I see some of the stuff that they put out, and it's hard to find somebody that agrees. It's hard to find two doctors that agree on everything, and that's our case as well. We do love some of the content we put out. There's some content that we don't necessarily agree 100%. Does HDL go low because of inflammation? Good question. I'll have to go back to the evidence and review that myself. Just from what I have seen so far, I think it might, but I don't think you have to have inflammation to have a low HDL. So that's kind of where I am on that. There's an if you say I'm guessing it means you mean ApoB, and yes, if that's the question. I did a CMT of the Tampa event, showed no soft plaque. My age 55 and arterial age was 31. What would be the next biomarker I should be watching with no soft plaque? We look at inflammation markers. We look at the lipid panel. We look at the metabolic panel with insulin resistance, liver enzymes. There are a bunch of stuff to take a look at. And an arterial age of 31, the only thing that it's saying is that the average thickness of your IMT is lower than the average people. So you're not even developing plaque, and that's a good thing. Congratulations. Non-HDL cholesterol blood test sort of tracks with ApoB if you can't get ApoB test. Yes, it does. Sort of. That's the right word for that. Sort of. Because ApoB will catch more of the other particles. That's the whole conversation about ApoB versus non-HDL. And non-HDL can also kind of correlate, but ApoB is still stronger. All right, so 1 hour mark, I promise. Thank you so much for all those who engaged. I'm sorry if I wasn't able to answer all of your questions. I appreciate your patience. Leave more comments below if you have more questions or you want us to cover other topics. I want to remind you about the practice. You can visit prevmedhealth.com or call 859-721-1414 if you want to have individualized recommendation with U.S. licensed practitioners. I hope this was useful for you, and we're open to see you next week. Oh, next week we're going to have an interview with Dr. Mark Cucuzella. You don't want to miss that one either. Thank you so much for staying, and see you next week.